So the reimbursement landscape for molecular testing is something that causes a lot of anxiety for molecular pathology lab directors. For the most part, we feel pretty well reimbursed for our lung cancer patients. That's kind of, that's one of the solid tumors that's been at the forefront of getting precision medicine and targeted therapies, so that's better understood and reimbursed by insurance companies. Other tumor types, it's kind of can be kind of hit or miss of whether they get reimbursed or not. It's also difficult if you work in an academic hospital setting to really have a sense of, out of the 100 tests we did these 2 weeks, what % of them did we get reimbursed or not? We try and beg to get that information, and we actually can't really get that because the hospitals are paid in a lump sum, and then a fraction of that goes to all of the clinical laboratories. So we don't have great feedback also as to exactly what our reimbursement is on a per test basis. The best feedback we get is if we get an angry email from an oncologist because they got an angry phone call from a patient saying they got a very large molecular bill. And so in those cases, we're fortunate that for our particular payer mix and population that doesn't happen too often. Then we try to work with billing and finance to kind of address those issues. But it's increasingly, and then recently with CMS's national coverage determination, the final version of that was a bit better than the initial one. The initial one said Medicare was only going to reimburse FDA-approved tests. So in the country, there is a single laboratory that does FDA-approved tests. So none of the lab-developed tests, none of the academic hospitals, they're saying they wouldn't be reimbursed. So that was kind of a panic for a couple of months. The final coverage determination allowed for local MACs, so local Medicare providers, to continue their coverage of lab-developed tests if they so wanted. So we are all breathing a little bit better now as far as reimbursement, but how the private payers are going to react and follow, how the local MACs might change their coverage is still kind of up in the air. So we're a little bit nervous about that. And then also with reimbursement, kind of more recently on the scene is the requirement for certain insurance companies for pre-authorization of all molecular tests. Some of them say all molecular tests, including molecular tests that have been done for over a decade that are super cheap.
HER2 and breast cancer?
Every test that my laboratory performs is under some insurance company's requirements for pre-authorization. These are some tests that, like, for example, after, not lung cancer, but after they get a bone marrow transplant and they're monitored serially, every 2 weeks for a long time, that falls under the pre-authorization. So most institutions don't have this great system set up to do pre-auth for genetic testing. Our radiology colleagues have figured it out, but that's a bit easier because they know you're going to come in and get your MRI in X date, and that's the date of service. And so we can get the pre-auth completed before you come in for your MRI, for example. For a molecular test, the date of service, depending on what kind of it falls under, if it meets the new 14-day rule or not, can be when the specimen is obtained. And you're supposed to have pre-auth done before the specimen is obtained, which is insane in the molecular pathology setting. It's just not physically possible. We've actually tried to spend a lot of time trying to talk to some of these payers, trying to get a sense of how do you envision this working, and how is this going to be practically executed? Because for our right now, our turnaround times are kind of pushing the max of what's acceptable for patient care and adding additional, day, weeks, God knows, sometimes pre-auth can take a month, depending on the situation. It seems acceptable for patient care. So I think the reimbursement issues right now are still up in the air, and there's a lot to be seen how some of these kind of things are going to shake out. And so
we've definitely had to sit down with payers, our local payers, just to sort of come up with some guidelines and some consensus. And we have some systems where we can sort of acknowledge for each time we ordered NGS that it conforms to certain specifications. It's an advanced lung cancer, and they haven't had NGS in the past 6 months, and with that we can facilitate the approval thing. I did think that the coverage determination had some constraints on how often you can do this, yes. Right? The idea is that you shouldn't need this more than once for a lung cancer, and I think that's not a reality. Okay, the fact that patients develop resistance, they develop multiple primary lung cancers. It's much more useful than just a one-time test. But if we're ordering it every month, that's a little too much, right? What is the cost? I mean, this costs like a brain MRI, more than a brain MRI. I mean, it costs less than a month of many of our modern therapeutics, right? And so sometimes we get overblown into the exact cost, right? If the moment is right and it's useful, we need to be able to order this test. And so I think we've made headway. We've gotten some thumbs up. There's still headway to be done, and we have to generate the data to make sure that we can convince payers that this is a test that is meaning not at one moment in a patient's care, but after resistance as well, and potentially many times.